no data to, but recently the recovery trial seems to suggest that there is some benefit in more advanced disease. So it's sort of making a resurgence in terms of its use in more severe cases, etc.
Okay. And
But
Fabivir.
yeah, that is still in trials, hasn't seen the light of day. US, there's no data as yet to suggest its use, so it's not being used.
Hmm.
Mm.
And
Very few. Even remdesivir, the data is marginal at best, but because we have nothing else to offer. So monoclonal antibodies really are the best option if treated early enough.
mhm.
But I think ultimately vaccine will be the solution.
And
Everything
low
else we do
molecular
will
weight
be.
heparin, you use at the lower threshold at the outset.
Beg your pardon again. Say that
So,
once more.
lower molecular weight heparin.
Low molecular weight heparin. So, yeah, there's been mixed reports about whether they need the 1.5 milligram versus 1 milligram per kilogram body weight. We use the standard dose. The data was
Prophylactic or
only
therapeutic?
from New York, which seemed to suggest a higher dose and that higher clotting disorders associated. But in reality, we haven't seen the same. So the rest of the country hasn't sort of seen the same. So people use standard dose because risk of bleeding with higher dose anticoagulation is there. So we just use standard dose anticoagulation. That too, not universally across the board, but in people who we might consider high risk for
And you're talking
anti,
therapeutic dose, not prophylactic, are you?
just the therapeutic dose. Yeah. So prophylactic also initially was tried and then was discarded because no efficacy found with the prophylaxis routinely, and the risk of bleeding seemed to be higher. So that's also fallen out of favor here. So we've sort of gone backwards from a lot of what we originally tried as more and more evidence became available that some of these don't work. People have gone backwards in terms of adopting some of these. So a lot of these have fallen out of favor. So actually, treatment has become much simpler in the sense of the number of options are minimal, very few. It's pretty standardized, it's across the board. And the rest is really moving to uh, non-invasive ventilation, et cetera, and then looking for vaccine as the option if people survive. So our mortality has gone down dramatically. So reflective of probably a younger population, uh, who are now coming to hospital if they get sick enough. But so mortality is low. Just infectivity rates are still quite high based on current variants.
Mm.
Mm.
George, what about the clustering? No, the first wave when US, they were in the East Coast like New York and
Yeah,
few
yeah, yeah.
states.
The
Um,
second wave, the biggest numbers were California.
uh-huh.
Now it started again. New York, New Jersey, we here in Massachusetts, Texas, Michigan, a few of the some of the hot areas again, sort of virus climbing a bit, probably related to travel and the UK variant, which is becoming the dominant strain here.
Uh-huh.
So that is making our life complicated. So we are seeing, we have sort of plateaued in our numbers. So our numbers are hovering between 2,000 and 2,500 new cases a day within the state. And so we haven't really gone down significantly.
Yeah.
And so concerns of surge four, fourth surge, we had gone down to about 1,000 cases and then started climbing again. So now we are sort of fluctuating between 1,500 to 2,500.
Yeah.
So
I think
that makes
we have few of our alumni who's joined. I think Arish is there.
oh, Harish,
Uh,
Ishwaraya.
yeah,
Oh,
and
nice.
Dr. Dublin from Vancouver.
Ah, okay.
Arish is
Hello
there.
there.
Hello, welcome, Dr. Dublin and Dr. Arish.
Harish,
Thank
how are
you.
you?
Good to see everybody.
Thank you.
Today is medical students. It's a college holiday, but we have sent the links. Yeah, faculty will be there.
Got it.
And I have circulated across the country and through all our IMA, then API, the ACP chapter, the Indian chapter. So I widely circulated, and also to the Punjab COVID group that is a task force.
Hello, Dr. Jones. Can you hear me from the auditorium?
Yes, I can.
Yes. So we would start at 8 o'clock and 45 minutes would be the talk. And then we would keep the floor open for questions and answers.
Sure.
Yeah, thank you.
Sure.
So Dr. Mary John is a new HOD of medicine.
Oh, yeah. Very nice.
You can wave one. Get you, sir.
Hello.
Dr. Mary is sitting in the.
Yes, yes, yes. I recognize you.
I think Pamela also is sitting in the front.
I'm ready whenever you're ready.
Yeah. We'll start in probably in 2 minutes. So.
Okay, sure.
I think, Dr. Ashish, we can start, I think.
Good morning. Good morning to the grand rounds. Today's grand round is very special because we've been building this grand. I think all our topics were being and being planned in such a way that this topic had to be done by the president of American College of Physicians, starting from genomics of the viral disease. Then we had how to detect this coronavirus and our own experience at CMC, and now we have Dr. George to give us a talk on update and the future. Before we ask Dr. George and Dr. George to speak, we will have our director and our principal to speak briefly. I will request Dr. William to introduce a little bit about the topic and give an overall view of what we are doing for COVID. Then Dr. Jairaj would introduce Dr. George, and then we would have the talk for 45 minutes, and then last 15 minutes we would have for the question and answer session. Thank you.
Morning. Last year, 2020, we were facing crisis of COVID-19 pandemic, and CMC was at the forefront of management of COVID-19 crisis. We were hoping in 21 we will be through, but as we are facing the second peak, and we have realized crises are not yet over. Since it's a continuous process of pandemic COVID-19, I am glad today Dr. George is with us. He is 1 year senior to me in MBBS, and he will update and tell us about the future of COVID-19. Dr. George, I welcome you on behalf of CMC Ludhiana, and I am sure today's talk will be fruitful for all of us, and it will further help us to get an update and how to manage our strategy as far as COVID-19 crisis is concerned. Thank you.
Thank you. Thank you.
Yeah. So it's my privilege to introduce Dr. George Abraham. He belongs to the batch of 1983. He did MBBS and MD from here, and currently is the Chief of Medicine at St. Vincent's Hospital, Worcester, Massachusetts. He's also a Professor of Medicine at the University of Massachusetts Medical School, and he's board certified in internal medicine and infectious diseases. The most important thing is he's the President-elect of American College of Physicians for the year 2021. And this is the largest internal medicine specialty organization in the world. And you'll become the president for the year 21-22 from May this year. And he's the first Indian and international medical graduate to be elected to this position in the 106 years old history of the college. So it's a great we have honor, and it's we are really proud of you, Dr. George Abraham. Dr. Abraham is also the chair of the Infectious Disease Board of American Board of Internal Medicine that certifies diplomates in the subspecialty of infectious diseases. He has received several awards. His research interests are hepatitis B, C, travel medicine, and infection control. He has authored over 100 publications, and he has written several book chapters, and he's an invited speaker at national and international meetings. And Dr. George Abraham was a lecturer in medicine when I did my internal medicine residency at CMC Ludhiana, and we have a long association with him. And whenever I used to go to US, I try to visit him if I'm visiting close by. And it's a great privilege to have you, Dr. George Abraham. Over to you to give the talk on COVID-19 update and future. Thank you.
Thank you very much, Jairaj, for that very kind introduction, and to William as well very fond memories of CMC and continue to maintain that relationship because that's still home for me, even though I'm physically in a different location right now. So good morning to everyone in the audience. It's 8 in the morning for you. It's 10:30 in the night for us here on a Friday night. So I will keep this moving just in the interest of time, and we can always carry a conversation after in a Q&A or other observations. I have no disclosures to make with regards to this presentation. So as William alluded to, 2020 was one which had a significant gap in our professional lives, and probably we all feel that we accomplished very little in the last year because we were so consumed by COVID-19. To briefly state, coronavirus is part of the family of coronaviruses. People will remember the SARS infection and the SARS coronaviruses, and when we had that in 2003 and 2004, and so this is a novel coronavirus in 2019, and they've stopped giving it any regional country name so as to decrease the stigma associated with the nomenclature, but it hasn't really changed much, at least in the United States. We do know that human beings are sort of accidental hosts, so the origin is still believed to be from vectors through bats, with the camel being the incidental host for the MERS coronavirus, and the other smaller animals like palm civets, etc., for the novel coronavirus and for the prior SARS-CoV. And humans are the end host, so to speak. There has been significant speculation about this being a laboratory-derived organism, but to date, the data points towards a natural mutation in the SARS-CoV family. And so coronaviruses are not unique to human beings. Our common cold is a coronavirus, and so are several other viruses that cause short-term viral illnesses. So these are mutations of that which led to this particular strain. The genome has been sequenced completely. Of interest are only two proteins, the spike protein, which is really the integral to binding to the ACE2 receptor, the angiotensin converting enzyme 2 receptor. And so without the spike protein, the virus cannot bind to the human host cell, and which is what has been exploited in the vaccine. So our antibodies that we develop is to the spike protein. And the envelope and the nucleocapsid proteins are probably more important from a diagnostic standpoint, but really not from an antigenic efficiency standpoint. We originally knew that the virus was an aerosol-driven virus, and we still believe that it's an aerosol-driven virus, and that's the primary mode of transmission. We no longer consider surfaces or other ways of contact being significant from our original concepts. What's most important to consider is that there are two phases to the illness. The original, or the first week of a 2-week course of illness is the viral phase, and then is the host inflammatory response. And this is integral to determining what modality of treatment we use. So the initial week of illness, so in the first 7 to 8 days of the illness, antiviral agents such as remdesivir, etc., would work. In the second week of the illness, truly the antiviral agents do virtually nothing and don't impact the outcome. And so you're primarily looking at the immune response. And so mediating the immune response is corticosteroids, IL-6 inhibitors, etc., which would be used at that point in time. So recognizing that here in the US, we sort of have put together guidelines which recommend if the person is within the first 7 or 8 days of presentation, then they would get remdesivir. Failing that, if they are more advanced, so 9, 10 days, 14 days into the illness, we really don't give them any antiviral agent at all. And we would only mitigate the inflammatory response and then allow them to recover spontaneously. What's most concerning is what's called a cytokine storm. So there is an unchecked inflammatory response, which can often be extremely massive, leading to multi-system and multi-organ failure, which leads to the ultimate mortality associated with the disease. What is not predicted is who will develop what severity of illness related to the cytokine storm. And so there is no way to anticipate other than to sort of speculate that somebody might be more prone to the illness. People have argued that the presence of diabetes, obstructive sleep apnea, obesity, etc., are risk factors to it, and probably are to some extent, but cannot have been exactly quantified. It's also well known that men are more prone to the illness than women. It's about 4.5 times more likely that men will develop complications than women, and that's been our experience here in the United States. Diagnostics really depends on what we are looking for in the blood as well as in the various body secretions, so saliva, and nasal swab or oropharyngeal swab, etc. So pre-symptomatic, usually there is a IgM which starts building up but often gets not detected. The IgM builds up during the first piece of the illness, the first few days, followed quickly by the IgG, which gets to a peak level and then stays positive probably for about 90 days, speculated. And we'll talk a little more about that. Otherwise, the IgM sort of disappears and then stays negative. And by the time symptoms are over, the IgG becomes the protective antibody in this situation. Now, what's interesting to note is that based on data from here, people who develop mild illness often may not have a critical threshold of protective antibodies. Our tests are binary, which means they are only qualitative and detect only a positive or negative result. So unless you have a semi-quantitative assay which actually measures the threshold of antibody levels, we would not be able to know who is protected from disease. So the fact that a person has had infection in no way guarantees that they would have protective levels of IgG to protect them for the duration. And this was reflected when I'll talk briefly about convalescent plasma. So one of the things we did here, we were part of a large trial which looked at the role of convalescent plasma. So plasma derived from people who had recovered from the illness to be used as a means of infusing passive antibodies into a person who had active disease in the hope of being able to mitigate the severity of illness. However, what we found was there was such a variable response, with some people having a robust response in terms of a rapid resolution of the illness, while others had virtually no effect whatsoever and often required a second dose and even then had no effect. And so what we essentially found was when we quantitatively analyzed the amount of IgG antibody, we realized that a lot of the people had IgG antibodies, but not of enough levels to provide adequate protection. And so the convalescent plasma program essentially came to a screeching halt because the feeling was the risk of a transfusion outweighed the benefit because the amount of antibodies in it would be variable and often marginal. So that's been abandoned here, but there are alternatives, which I'll come to in a moment. The challenge in diagnostics appears to be the following. The patients who get infected are likely to transmit illness even before they manifest with symptoms. So unlike most other viral infections, common cold being a classic example of another coronavirus, most people are infectious when they are symptomatic. People in COVID-19 are infectious even when they are in the pre-symptomatic phase. So at least 48 to 72 hours prior to their manifesting symptoms, they are already shedding virus in their secretions and are potentially infectious, which is what has led to the aerosol-driven spread of illness because people appear normal or are asymptomatic, but could still be asymptomatic shedders of the illness. So factors around higher shedding include obesity, people who have sleep apnea, etc., seem to be high shedders of virus compared to others who may be low shedders. And usually the virus harbors in the nasopharynx, which was why initially nasopharyngeal swabs were used. Now mostly nasal swabs done, and a lot of tests here, several studies, especially from Yale, which have looked at saliva-based testing and using saliva as the surrogate, which is a much easier specimen to obtain than a nasal swab. And we've sort of abandoned doing nasopharyngeal swabs anymore because nasal swabs are much easier to get. We've trained our nurses to do it so that you don't need a physician to do it each time. So with the challenges of treatment come the controversies around treatment, and I'll show you some of what we have adopted and some of what we have discarded in our treatment regimens here in the US. So among the various options, I alluded to convalescent plasma. So we've stopped using convalescent plasma. Among the other drugs, azithromycin is no longer used, ivermectin is not used, hydroxychloroquine is not used, tocilizumab is used, and I'll comment on that briefly, and dexamethasone is used for people who are hypoxemic, so 94% or less on pulse oximetry, or an arterial blood gas estimation demonstrating arterial hypoxemia. These people would go on dexamethasone based on the UK study, which looked at it. It's 6 milligrams per day, and it could be 10 days, could be longer, depending on what their state of recovery is. And so dexamethasone has sort of become the mainstay for people who are hypoxemic. There's a low threshold to initiate that. The controversies around hydroxychloroquine, ivermectin stem around these three individuals. So there were large studies published both in the Lancet and the New England Journal of Medicine. It was designed by a company called Surgisphere, which was led by an Indian American named Sapan Desai. So Surgisphere is this company who claimed to have access to data from several countries all over the world. And what they said they had done is basically connected with electronic medical records of countries all the way ranging from Australia to the UK to several African countries and several European countries and several South American countries, and had received large amounts of data, claimed to have a huge database, which they then analyzed. And so they had done a significant analysis about the use of ivermectin and hydroxychloroquine. Co-collaborators were two others. Mandeep Mehra is an Indian cardiologist who works at the Brigham here in Boston. He's a professor at Harvard Medical School, young fellow who's published pretty extensively. His primary work is in heart failure and heart transplantation. Bright fellow, I know him. And so he was one of the lead authors. And Amit Patel was a professor at the University of Health Sciences in Salt Lake City, Utah. And Sapan Desai was the owner of this company called Surgisphere that had the data. So the studies were large. They were fairly well designed, or appeared to be well designed, large amounts of data which were analyzed. And the data was owned by Sapan Desai with his company, and these two were the co-authors among several authors on those publications. So somebody along the way looked at some of the data, and the data which was quoted from Africa, especially for ivermectin, was believed to be erroneous. And so someone wrote to the editor of the Lancet and said, Dr. Richard Horton questioned the veracity of the data. So that led Lancet to ask the authors to provide the actual data set from which they had done their analytics and published their data. At that point in time, these two authors claimed that they had no access to the data set. And Dr. Desai was asked to provide the data set and said that under permission granting from the original hospitals that provided the data, he could not release the data. That led to further investigation, and essentially the hospitals that had so-called provided the data essentially came back to say, we provided no such data. So it essentially got blown up into a huge controversy where the data was found to be essentially fabricated or bogus. And that led to two famous indictments. Both the New England Journal as well as the Lancet retracted the article, saying that they could not substantiate or validate the results because the underlying data could not be substantiated. And so that fell by the wayside. However, there were countries like Peru and Colombia, et cetera, who had bought large quantities of ivermectin and were basically giving it to everyone in the country, thinking that it was going to be helpful in preventing their COVID-19. And so it was the story in Brazil. And as we know today, many of these countries, Brazil is virtually on the brink of collapse from the number of cases of COVID-19. They're just totally both economic and healthcare disaster, because they just can't take care of the number of cases that have increased. So dangerous in COVID-19 has been this pre-publication world. A lot of the data gets released and the articles get released into the public domain before they are peer-reviewed. And so journals have taken a hit in terms of in their rush to publish large so-called well-done trials that they often don't look behind the scenes to see if the data is valid. So this is the latest, this is a meta-analysis of 14 studies just published a couple of weeks ago, essentially suggesting that hydroxychloroquine has absolutely no effect on COVID-19. And so our former President Trump was one of them who proposed that hydroxychloroquine was this miracle drug leading to a run on hydroxychloroquine. And then India was producing more hydroxychloroquine to share with the rest of the world. But essentially that has fallen by the wayside. The FDA has removed any emergency use authorization for hydroxychloroquine. It is no longer considered a drug of choice. Similarly, this is data from JAMA, which showed the ivermectin study. This was done from Mount Sinai in New York, where they did ivermectin versus placebo and essentially showed no benefit of ivermectin over placebo in COVID-19. And so ivermectin is not used in the US for COVID-19 because our feeling is the data does not support the use of ivermectin and that there is no value to the use of that. It's my understanding it's used in India, but I think overwhelmingly the data suggests that it may not be, and some of it may have been driven. So in most viral illnesses, the problem is that whether you use certain agents, people get better whether you use it or not. So unless you do rigorous placebo-controlled trials, it's often very difficult to differentiate whether the person got better because they were going to get better or they got better as a result of our treatment interventions. Similarly, people have looked at the role of zinc. Because zinc is an antiviral agent, people have looked at the role of vitamin C, essentially demonstrated no difference whether they were used or not used, and didn't make any difference either in the duration of illness or the outcome of the illness, and so they are no longer used. Remdesivir has received some criticism because Gilead, the company that manufactures it, was in a rush to get it approved because they were afraid that it would not reach statistical significance based on a big trial done by the WHO called the Solidarity Trial. So recall, remdesivir was originally discovered as a novel therapeutic agent in the role of Ebola and was looked at for treatment of Ebola. It didn't work against Ebola, and so it was actually shelved till such time that they started looking at it for COVID-19 when they were looking for novel therapeutics. So the ACT trials were trials which Gilead sponsored in the US and in several other countries, looking at the role of remdesivir and seemed to show some benefit. And then the Solidarity trial came along, which was a multi-country trial run by the WHO, where they allowed both standard of care in each country, whatever was that standard of care, and the use of remdesivir, and seemed to demonstrate that remdesivir seemed to have a benefit. So this is a plot which would show everything to the left of the midline. So the midline is taken as 1, which means no benefit. Anything less than 1, which would be considered with benefit. Anything more than 1 would be considered harm or no benefit. And so the data seem to suggest, so these are called box and whisker plots. The box and the whisker, the length of the whisker is the 95% confidence intervals. So essentially demonstrating that there might be some benefit of remdesivir. Recall that the benefit, if at all, is relatively marginal, but that won them an emergency use authorization. And so this is our only antiviral agent, which we use during the viral phase of the illness. We don't use it during the latter phase. So remdesivir is only indicated in the first week of the illness. By the second week of the illness, we don't use it at all. And there is actually data to support that if people are on a ventilator or on high flow, etc., they actually do worse with remdesivir than not. So we don't use remdesivir at that point in time. We would only use immune-mediated agents such as the IL-6 inhibitor or steroids in that situation, and the supportive care, high flow, etc. So remdesivir early in the illness may have some benefit. It's a 5 days course. They tried a 10-day versus a 5-day and showed no benefit of 10 days over the 5 days. So we now use a loading dose of 200 milligrams on day 1 and then 100 milligrams daily after for 4 more days for a total of 5 days of illness. Switching to the inflammatory phase, the IL-6 or tocilizumab manufactured by Roche. So the initial trials by Roche themselves seem to demonstrate no significant benefit of IL-6. And so it actually is a fairly expensive agent, and it's a single dose that's used. And so that got shelved. So it was initially used, then we stopped using it, saying there is no benefit. Recently, there has been a recovery trial which was published, which seems to show that in people who are either ventilated or advanced respiratory failure or on multiple pressor agents, etc., so advanced multi-organ failure may show some benefit with it. So it's resurfaced as a potential agent in the armamentarium to be used in the latter phase of the illness where there is more severe inflammatory storm. And dexamethasone is used in the same phase of the illness. So what's generated interest from the convalescent plasma studies are the role of monoclonal antibodies. And so there are several studies. This is the Lilly combination, and there is Regeneron as a combination, and people have looked at combination antibody cocktails. So gained some fame because the President Trump, when he was hospitalized with COVID, got the Regeneron version of these antibodies, but essentially shows that early in the phase of illness, so in the day 1 or day 2 into the illness, before significant hospitalization, if antibodies are given, similar to the convalescent plasma, but in this situation, you're giving a concentrated cocktail of antibodies, and showed a tremendous benefit in terms of being able to mitigate the severity of illness. So they are approved now for use pre-hospitalization. So even before they get into a hospital, as soon as they're diagnosed, if a person is given a single dose of an antibody cocktail, then it prevents hospitalization in a larger majority of these patients, and they go on to have a much milder course of illness. So these are relatively popular, not universally accepted or used, but are being increasingly used in the US, given there are multiple antibody cocktails available now in the United States for use. The only other caveat is if an antibody cocktail is used, there is a 90-day waiting period before they will be given vaccine, because the antibody levels remain in circulation for about 90 days and they block the effect of the vaccine. And so these people would have a 90-day hiatus before they get a vaccine of any sort. So what was the story? The US, as the #1 country in the world, the most affluent and the most wealthy, but yet has the highest number of deaths, over 500,000, over 500,000 cases, and several million worth of cases of illnesses, hospitalizations, etc., which has really led people to scratch their heads and say, why is it that the #1 country in the world, which has the most affluent healthcare system with the most money that they blow, how is it that we had the worst outcomes and the worst statistics and the highest number of cases worldwide? So big challenge. Our previous government, led by our prior president, was very anti-science. And so they had their own fixed ideas, and they seemed to marginalize all the physicians, the scientists, and everyone else who provided scientific basis for the disease and the illness, and made it a lot about their personal beliefs and politics. So there was not much focus on developing testing strategies, developing personal protective equipment. So we were at the bottom of the list when it came to the number of tests available per people compared to most other countries in the world, including several developed countries. And so we suffered that way. Many other countries in the world effected a lockdown. We were unable to control mobility, because even if we did a lockdown, many of the governments, state governments, did not subscribe to it, feeling that it would cause an economic barrier. So people continued to move around as usual. And so we were never able to contain the virus because of ineffective lockdown. We had a white versus black problem, or the majority population versus minority, ethnic minorities, and the fact that generally disease was worse in this population, but also socioeconomically they were worse and more affected. and people only cared about the larger majority population who controlled economically and politically the access to the country and its access to testing, diagnostics, treatment, etc. So reflective of that, Blacks, Hispanics, Native Americans, etc., had much worse illness compared to the white population, which was much less. We had to teach people to alternate ways to greet other than a handshake. And so all the different ways of greeting each other had to be taught. We had to teach people the concept of isolation and quarantine, which was a challenge because people are normally used to just walking around. They don't like government telling them what to do. And so that was a challenge. People love to go out and eat, have parties, socialize, etc. And so we had to create lockdowns where restaurants could not be serving large amounts of people so that there would be spread of disease because they couldn't be masked. People love to go on vacations, and so all vacations got shelved. Travel essentially shut down. Restaurants and hotels all shut down because mobility was restricted significantly. The anxiety levels built up, and it was tough. People started getting more and more stressed. They couldn't deal with the stress and anxiety of illness. A big challenge then and even now were schools. So all the schools closed, all education went to online only. So young children were particularly affected and are still affected because schools have not opened completely. They are in the process of reopening, but children didn't have any social interaction with their peers and just sitting in front of a computer. Absenteeism grew dramatically, people's grades fell, etc. Colleges, same issue. Young adolescents and teens don't know how to socially distance. And so therefore they had large outbreaks in colleges because large dormitories were completely ridden by virus because these kids were all partying together. And we had school teachers. We still have school teachers who object vehemently to returning to in-person school, saying they are the ones who are most at risk and that they're going to be exposed. Most of the older teachers retired, and it's only the younger teachers who are remaining to be able to teach because the older ones are afraid that they're going to acquire illness while in school. The whole concept that surfaces all needed to be cleaned because virus would spread off surfaces has now been debunked. We now accept that other than aerosol, there's really no other significant transmission from direct contact. A lot of us in the medical profession went to telemedicine using televised video-assisted platforms to be able to communicate with patients who couldn't come into the hospital. And so we were communicating that way. Worked for some people, didn't work for others. So here we were sitting and looking at computer screens and trying to figure out, obviously you can't do a physical examination. So you were teaching patients how to palpate their livers and their spleens and look for lymph nodes and look for rashes. And that was about the extent of the examination that we could do as we tried to take care of problems during the acute events. Social isolation. Our elderly, a lot of them live in nursing homes and a lot of them were extremely isolated. Families could not visit because during the initial phase of the illness, a lot of these older folks died when they acquired a disease just because they were so vulnerable and the disease spread so rapidly. And even in hospital, we don't even now allow visitors or family members to visit people who are infected. And so we do this sort of FaceTime using either a smartphone or an iPad. And so we communicate. So this way, the daughter or son or other family members can communicate with the patient themselves so that there was some way of maintaining contact both for the patient's sake because of the loneliness and isolation, and for the family members to know that their loved ones are staying safe. So as expected, hospitals took a major hit financially, by the millions and millions of dollars. So a lot of physician salaries got hit, people lost jobs. So as the numbers increased, the economy plummeted. And we still are, a lot of our conferences are online. So, you know, you slept in the conference room, now you slept in your bed because you said you were attending the webinar. And so you could basically log on, black the screen, turn off your microphone, and then go back to sleep. We ran into ICU shortages. So we did a stand-up ICU. So we converted our post-op recovery room into an additional ICU to field. We had 30 beds in our original ICU. We stood up a second ICU to take care of non-COVID patients, just so as to be able to cohort all our COVID patients into ICUs rooms. We put up a field hospital, essentially using tents and temporary shelter to converted one of our large stadiums into a field hospital to take extra patients to be able to control, to get beds. Otherwise, patients were crowding in the emergency room waiting to be admitted, etc. And a number of countries around the world have taken a similar hit. So the lockdown has had huge challenges. We still have a problem. The economy has taken a huge hit. People's wellness have taken a huge hit. And we have run into all sorts of problems. It's interesting that the CDC released that the third most common cause of death in the United States in 2020 was COVID-19, just to give you a perspective of how severe the effect of COVID-19 was in the US. And with that led to significant amounts of stress, even among us as healthcare workers. So we struggled through the exhaustion, mental exhaustion, physical exhaustion of going through treatment, taking care of people who are dying. It's tough. It's still emotionally tough. I personally, for example, for the last 15 months have worked continuously 7 days a week, every single day, because I've had to lead the COVID response in our own institution, and that's been challenging in many ways. So then the promise of the vaccine was, somebody said it was a shot in the dark. Would it work? Would it not work? Nobody knew enough. And so where we are now is we are 3 vaccines later in the US, and show you briefly where we stand and going forward. So the viral genome has been sequenced completely. As we talked about the whole sequence, out of that, the area of interest is the spike protein. And so to understand how these vaccines work, it's good to understand our basic immune physiology. And so we normally know that when a virus or something else invades the cell, it forms epitopes which are there on the cell surface, and the circulating immune cells, which are the T cells and the B cells in circulation, will be like scavengers, go around, and once they see the presence of the epitope on the surface, which they recognize as foreign, the killer T cells will latch onto it. They then stimulate memory T cells to be formed, which then recognize the antigen so that if challenged with more, it will mount an antibody response. It also harnesses the B cell response, which is a humoral immunity, circulating antibodies. It develops antibodies, as well as there are memory B cells, which also store the same sequence and antigenic profile. And so that's what really generates the memory response, as well as the generates the antibodies. And so what we're doing with vaccine is harnessing this whole process. So the first 2 vaccines to come out were the messenger RNA vaccines with Pfizer and Moderna. I know both of them are not available in India. They were the first to come out in the US, and they are the most prevalent vaccine in the United States today. So they are novel technology. The technology has been in existence, harnessed for this particular vaccine has been novel. So essentially what they did was took a portion of the messenger RNA that carries the code for the spike protein. And since this antigen cannot enter into a host cell because the scavenging T cells will kill it outright, they coated it with a lipid nanoparticle to basically make it a stealthy entry into the host cell. The lipid nanoparticle prevents the antibody from recognizing the antigen till it enters the cell. Once it enters the cell, it harnesses the host DNA to develop antibodies to that specific code, which is the antigens to the spike protein. Ultimately, those antigens push out to the surface. The mRNA basically dies out. The antigen pushes out to the surface, at which time it harnesses the immune response in terms of antibodies. The T cells and B cells form the antibodies and ultimately destroy these cells, but that memory is preserved. So when actually challenged with disease, they quickly mount an antibody response and prevent infection. So that's the basis of the vaccine. So the messenger RNA vaccines are that way. And so because of the lipid nanoparticle is unstable at room temperature is why it needs a cold chain, the Pfizer one needing much higher cold chain than the Moderna one. And so that's why they are required to be maintained the way they are, and which makes logistics of giving vaccine difficult. So both the Johnson & Johnson and AstraZeneca, which was the Oxford vaccine, which is available in India as Covishield, use viral vector technology. So they use adenovirus. So adenovirus normally causes a common cold in people. So what they do is take out a portion of the DNA. So they make it what we call replication incompetent. So it's not able to multiply in the body because the whole DNA, a portion of the DNA is missing. And what is inserted instead is the coronavirus DNA to the spike protein into that viral vector. And so the virus then is allowed to infect, enters the human cell. So it basically transports that portion of the coronavirus DNA into the host. The DNA then harnesses the host mRNA to develop antigen. That antigen will again go to the surface, stimulate a T and B cell response, and then develop antibodies. And the same process is accomplished as with the other. So the essential process is the same. The transfer of viral antigen into the cell could be either as an mRNA or as a viral vector-based vaccine, and that's the only difference between the two. Advantages to the Oxford vaccine or the AstraZeneca vaccine is the storage is at room temperatures, and so there were no specific storage conditions, which made it much easier to be able to be manufactured and distributed in large settings without all the antecedent costs of a cold chain. So AstraZeneca developed its vaccine and released its vaccine. It was manufactured in India and it's being used in India and many other parts of the world. However, a couple of caveats about the AstraZeneca vaccine to understand. So accidentally, AstraZeneca in its original trial, or the Oxford group in their original trials, one subgroup of the original cohort got only half the dose of vaccine compared to the other cohorts which got the full dose of vaccine. So they labeled it the low dose and the standard dose vaccine. And so they measured the antibody responses and found that people who got the low dose as the first dose, followed by the standard dose, so half dose, full dose, had a much better response rate than the people who got the full dose response. So the standard dose in each category had a much lower response rate compared to. So that created a fair degree of consternation that there was some error in calculation in the dose, etc. And so Oxford had its suggestion. Are you able to still hear me?
Yeah.
Okay. Sorry. My computer all of a sudden. Okay, so Oxford to compensate for that loss in efficacy with the standard dose, stretch the interval between two doses to 3 months, 90 days. So what they've done now is give one dose and then wait 3 months to give the second dose, essentially trying to mimic the low dose so that as the levels come down, they give the second dose as a booster. And I believe in India, I'm told now that the government is looking at extending that interval from the original 4 weeks to at least 8 weeks or longer. And so we strongly recommend that. In the US, it's still in trials. Its data just got released, about 78% efficacy using the same standard dose format. But people are looking at stretching the intervals in between for Astra just to be able to make sure that it meets the efficacy standards that was expected. So with both Pfizer and Moderna, which are 2-dose, and with the AstraZeneca vaccine, the first dose gives about a 50 to 60% response rate, and so requires that second dose as a booster somewhere between 3 to 6 weeks after. So it doesn't have to be exactly at the 3 or 4 week mark. It could be a week or two later in case of the Pfizer or Moderna, even later if it's the AstraZeneca, gets a second dose as a booster, that really boosts it to the over 80-90%. The challenge is both Pfizer and Moderna came out before variants were recognized. So now we have at least 3 known major variants, and there are a number of minor variants here in the US, and I'm sure there are several in India as well. So the B.1.1.7, the UK variant, was the first. It's now expected to be the most prevalent variant in the US right now. About 60% prevalence. There's the South African variant, the 1351, and the P1, which is the Brazilian variant, which is the most recent, which has basically killed Brazil because they're getting the Chinese vaccine and it has no effect against the Brazilian variant. So they've stopped immunizing using the Chinese vaccine. So this is to show three-dimensional modeling of the actual coronavirus spike protein and to show you of note are certain players. So what are these variants? So variants cause what is called immune absence. So essentially a portion of the genome actually disappears. So the antibody is looking for specific antigens on the protein of the spike protein, but those completely cease to exist. So as a result, it kills it. And so because of that, they just are not able to lock in place. And so the vaccine stops working at that point in time. And so that's the challenge. So comparing all three vaccines, there are some common areas which are immune deletions, so to speak. So deletions of antigens leading to the immune absence, so to speak. And that efficacy, it limits the efficacy as well as the antigenic potential of each of these variants. And so that is the problem. So if you look at Moderna and Pfizer, you see the drop in efficacy with the South African variant by about 20%. So they come to about 70% from their original 90%, and that is the challenge. And so that's why of particular concern was the AstraZeneca, because this was data from South Africa saying that in mild illness, there was no difference between placebo and vaccine. So saying that it was not effective against the South African variant, they stopped using the AstraZeneca vaccine in South Africa. So it is still active against the UK variant, but not active against the South African variant. So these are the current vaccines available. The Russian vaccine, which we don't have clear data about, partial data. The Chinese vaccine also a bit questionable, but at least the other four major vaccines are well established and used in many countries in the world. So what's also important to note is that people will still continue to have heart attacks, strokes, cancers, etc. Just because that happens after they've gotten the vaccine, not everything is because of the vaccine. So we tend to implicate all life events being because of vaccine after, but in reality, that is not true. Things will still continue to happen. Not everything is because of vaccine. We do know now that no one, 100%, all the vaccines protect against serious illness leading to hospitalization, deaths against coronavirus, especially serious illness, and 0 deaths from the vaccine itself. In fact, the risk of serious complications is 2 per million. And so it's extremely low. They're very safe vaccines. What's also important to note is that people who have gotten the vaccine tend to transmit infection much less. This is cycle threshold. So the higher the cycle threshold, the lower the amount of virus in the person. So you see the rise in cycle thresholds after 12 days of getting the first dose of vaccine, essentially suggesting that people who get vaccine not only don't get severe illness, they may have very mild or no illness, but they are also low transmitters, which is why the big push to get vaccine out to everyone. Should pregnant people get the vaccine? The short answer is absolutely yes. About 30,000 people in the US have received, have had pregnancies, either accidental or otherwise, post-immunization, and children born none of them have had any fetal malformations. So we now know that it is safe in pregnancy, even though it was not tried in pregnancy during the trials. And we are now doing pediatric trials. So we have data from 12 years and older to show that these vaccines are safe and work. We are now looking at ages from 6 to 12 to see whether that age category will work as well, because we ultimately need our children to be immune as well. Interestingly, there are 4 studies which show that people who have had COVID-19 with 1 dose of vaccine, they boost or they get such a robust immune response rate, and the second dose actually doesn't increase that response rate much, suggesting that people who've had COVID-19, only 1 dose of vaccine may be adequate and they may get enough of a response rate. So there are 3 other studies which demonstrate the same results. So that's being looked at in the US and elsewhere in the world as a means to conserve vaccine and to be able to make it available for more people. From a risk assessment standpoint, unless there's true anaphylaxis, they don't need to be prevented from getting vaccine. Essentially, food allergies, drug allergies, etc., disease states are no contraindication to vaccine. Everyone is a potential candidate for the vaccine and should be given it. Most of the vaccine reactions are related to the use of polyethylene glycol or PEG. And so that's being studied as to why that triggers a reaction when it's injected, but people use it as a colonoscopy preparation, et cetera, to clean out the bowel, and nobody has a reaction to it. You can have local site reactions, which may vary in severity to varying levels, but these are all normal and tend to disappear over days, and so are not causes of worry. From the US, we now know well that because of vaccination, the effect of hospitalization is dramatically improved. We used to have at least 100 to 200 employees getting sick per month before vaccination started. After vaccination, we have had 0. So it's a dramatic drop. So vaccines definitely work and is probably our only source or confident treatment option to be able to mitigate this disease. No other treatment options are really as robust. The challenge is to measure or sequence virus for variants. Even in the US, we do only 0.5 to 1 to 2% of our specimens that are randomly sequenced to detect variants. We need to do a lot more, as do many other countries, to be able to detect these variants early and hoping that we can tamp down disease by using vaccine. Just this week, we got approval for non-prescription home-based testing, costing about $10 a test, about 700 rupees or 750 rupees. And it's a simple self-swab. Will give you an answer in 15 minutes. And we hope that will increase the intake of testing when people can do it in their own homes. There is a long NIH study in progress, which has just started looking at the whole concept of long-haul COVID. So people who recover from illness but are left with comorbidities which may last months to even a year. And so that's a hot area which is being studied right now. Here in the US, as with the rest part of the world, we are really moving. The challenges of reality is there are minority populations which really just don't get access to healthcare and to vaccine. While equality is good, that still doesn't get them there. Equity is good, where they need to be given preference to be able to get easy access. Ultimately, we want to remove all barriers. And that's so, I'm sure, with every country in the world, including India. Social determinants of health. So multiple different literacy, language, etc. So many different other factors that play into the access of vaccines. And that's a hot area of debate here in the US. So we still continue to maintain our distancing because that's important. Our vaccines are not 100% effective. And so there is people, we have documented cases of people who've acquired disease after having received both doses of vaccine. So that does happen. We still need to use masks. The CDC came out with newer recommendations for masking. If you were to use a surgical mask, they encourage you to loop and tie a knot at either end so that it fits very tightly and snug over the face. So either knotting or using a double mask, using a cloth mask and the surgical mask being on the inside. So surgical mask on the inside, cloth mask on the outside works to almost 95% filtration. So that's what CDC's current recommendation is for masking. Obviously, vaccine is critically important to help control disease. So I'll stop there at this point in time and entertain questions. And I apologize if I've gone over time.
Thank you, Dr. George. There are around 20 questions in the chat, and we have 5 minutes to go. So we need to be very quick. Can markers predict a cytokine storm?
Can what create a cytokine storm, please?
Can markers predict cytokine storm?
Markers to predict cytokine storm. Yeah, people have measured the IL-6 levels. So we measure the IL-6 levels and that was the initial recommendation. So if the IL-6 level was elevated, then you use the IL-6 monoclonal antibody. Of late, we don't bother. If there's clinical indicators of hypoxemia and respiratory distress, you're using non-invasive ventilatory methods, etc. We already assume that person is in a cytokine storm, and we go ahead and would offer at least dexamethasone for starters, and we might end up using the IL-6 inhibitor tocilizumab. We don't necessarily measure them anymore because the test is expensive, takes days to come back, and by then it can be seriously delayed in terms of care. So we don't measure as much anymore.
What about
Does makeup of a person affect the disease process or severity of the disease?
I missed the first part. Somebody else was speaking as well. Could you repeat that first part of your question?
Does genetic makeup of a person affect the disease process or
Oh.
severity of the disease?
So the genetic makeup, yeah, interesting question. As best as we know now, we know gender makes a difference. We know age makes a difference because we have what's called immune senescence. So our immune system is not as robust with advancing age. And so therefore our ability to prevent infection is not as robust in that category. And so therefore we know elderly are more prone. Comorbid illnesses, so diabetes, hypertension, respiratory illnesses such as obstructive sleep apnea or COPD, etc. So genetic markers specifically have not been studied. And so we don't know if there are genetic markers which might predict in the future. At this point in time, we use either a host of diseases or gender or other characteristics such as that to make a determination as who might be more likely to get illness.
What is the role of anticoagulants? The role of anticoagulants.
Anticoagulants. Okay, excellent question. So the role of anticoagulants. So early in the illness, there was a study published from New York. When New York had the big surge, they published this data where they showed a series of deep vein thrombosis or pulmonary embolism. And so they recommended using 1.5 milligrams of low molecular weight heparin per kilogram compared to the standard dose of 1 milligram per kilogram, stating that higher dose and everybody should be on a prophylactic anticoagulant. That data has not been replicated elsewhere. And through the rest of the illness to date, we have not been able to demonstrate that. So to date, there is no recommendation to use either prophylactic anticoagulation or to use higher doses of anticoagulation in these patients. If people develop respiratory distress, either a CT scan or something else is performed so as to be able to determine if they have pulmonary embolism. And if they do, they are treated the standard way as everyone else. There is no recommendation to use a hypercoagulable protocol. So there was also of note that the AstraZeneca vaccine has received some criticism in Europe, particularly in Germany. There was a spate of cerebral venous sinus thrombosis, which occurred, a series of cases, which was more than the usual. And so they attributed it to vaccine related. However, the European Medicines Agency and the WHO have not subscribed to that. So as of now, there is no recommendation to stop using it, but some countries have, while they reevaluate whether there is a hypercoagulable risk, specifically with the AstraZeneca or the Oxford vaccine. But the other vaccines, there is no such implication.
The next question is there any data on vaccination triggering a flare in autoimmune disease?
Vaccine and what, I'm sorry?
Yeah, is there a data on vaccination triggering a flare in autoimmune disease?
So yes, so a flare in autoimmune disease, people who are immunosuppressed, advanced HIV, people who are in cancer chemotherapy, none of them are contraindicated from getting the vaccine. They should get the vaccine. Will we get the same robust response rate? Probably not, because they have some degree of immune attenuation, but no one is contraindicated from getting the vaccine. There is no waiting period. So if somebody gets COVID, they don't need to delay getting the vaccine by 90 days. That is a myth. There is no basis for that. The only recommendation is to not give vaccine when they have acute symptoms. And the only reason to do that is because symptoms from the vaccine would not be differentiated from symptoms from the disease. So I say symptoms from injection need to be separated from symptoms from infection. And so when they are having acute symptoms, they would be similar and you wouldn't be able to differentiate. That's the only reason to delay the vaccine, but otherwise, there is no waiting period before getting the vaccine. So people who've had disease should still be given the vaccine. Whether 1 dose versus 2 doses is still up in the air. There is no firm recommendation. As of now, here in the US, we give 2 doses to everyone, and that's the protocol around the world. The only countries like the UK who have done 1 dose first is only so as to be able to allow more vaccine to be available to more people, not because there's a scientific rationale to delaying a 2nd dose.
Hello, George. Thank you very much for that exhaustive presentation. I'm very proud to say that here at CMC, we are almost at par at therapeutics. We're almost following all what you have said. There are some exceptions. We don't have testing for IL-6 available. It's expensive, like you said. So for diagnosing cytokine storm, we do the CRP levels. So all patients have their CRP and D dimers on admission, and we kind of follow that. And like you said, oxygen saturation is also the patient deteriorates, then we think about it, and then we kind of change our management also. Second, one question I want to ask you is about reinfection. What are the rates of reinfection that are present, and what is the cause?
Yeah, excellent question. So just I alluded to earlier that people who've had mild disease have low antibody levels of protection. Those are the people who get reinfected. So it is well described. People are reinfected, and some people do get infection even after both doses of vaccines. So it's a low prevalence, maybe 1 to 2%, but not very common, but not uncommon. So we shouldn't rule it out, because reinfection is possible in people who've had disease before, especially mild disease before. People who've had severe disease may not have reinfection because their antibody levels are excellent. Patients who end up in the ICU are on high flow or intubated. They tend to have more prolonged disease, shed virus for longer period of time, and the preferred specimen for them is an endotracheal aspirate rather than a nasal or a salivary specimen to diagnose disease, because the endotracheal aspirate would be a much better and more accurate specimen to be able to isolate virus. So to your other points, I think they're absolutely well taken. We also don't routinely measure IL-6 levels. We just go ahead based on all the clinical parameters, etc. We do occasionally do CRPs. Unfortunately, CRP being an acute phase reactant tends to get elevated during any inflammatory condition. So I think it's great to use certain cutoff levels or trends. I think that's a great way to determine cytokine storm. But your clinical judgment, I think, is more than adequate. And knowing that people who become hypoxemic have increased respiratory frequency, respiratory distress, etc., we are in a cytokine storm at that point. And it's great to intervene then rather than wait till they are in extremis. And at least dexamethasone can be safely used, and those patients will do and will turn around better. So I think it's great to hear that you're doing, as what I said, we have gone backwards in terms of lots of things that we used before we've stopped using. It's become less and less, and we recognize now that our therapeutic armamentarium is limited. Our vaccine is our only prayer to be able to try to control infection rates.
Good morning, sir. Good morning, sir. Thank you for the presentation. Just wanted to ask, how long do we continue anticoagulation after discharge for severe to moderate cases, or do we continue?
So we don't. We stop it when they leave hospital. So we don't. There is no recommendation even to continue steroids once you discharge them home. So you can discontinue both. I don't think there's any recommendation that they would recall. Once the inflammatory phase is coming down, which is by the time that you're discharging them home, then there is no more basis for a hypercoagulable state or no more basis for respiratory failure. So we basically stop all of that or taper them rapidly by the time of discharge. We don't continue them after.
So do we recheck a D-dimer level, or so as
we don't? No. It's our clinic. Your clinical judgment is probably the best. We do that. We don't do any repeat testing. We don't test after test of cure. We do not do that because people will carry the antigen for a long period of time, and so they may remain positive. We know well that these people, so 14 days in people who are non-intubated, 21 days in people who are intubated is the average duration of when they are potentially infectious. After that, they are not. So we do not do repeat swabs as test of cure. And so that shouldn't be done because people may remain positive, which is well proven. There's a nice South Korean study which proves that none of them have actively culturable virus. This is just viral remnants that remain in the nasopharynx. And so they continue to give a positive test, but they don't imply active disease. So they shouldn't be retested for as a test of cure at discharge or any time after.
Thank you, sir.
Can you tell us a little about this antibody testing. A lot of people are going and doing antibody testing after the vaccination or just before the vaccination. Because I think neutralizing antibodies is what we should be testing.
Yeah, great question. So antibody testing post-vaccine. So it's not recommended to do that because the antibody levels they rise over time, and the detectable antibodies. So you have to have a test which is accurate and which is semi-quantitative. So what you're testing for is antibody to the spike protein. So the antibody test that you're using has to be able to detect antibody to the spike protein, which is what is really being induced by the vaccine. And number two, it has to be a semi-quantitative test, which we should be able to pick up a threshold, because above that, you may still be below it, but when challenged with disease, you mount an immune response enough to be able to protect oneself. So detectable antibody titer is not equated with evidence of presence of absence of immunity. So not recommended. Here, we don't check for antibody titers post-vaccine. People still do it out of curiosity, but in reality, it's not recommended nor required. And the test often may not be the appropriate test. And so the result comes negative and people say, oh, the vaccine didn't work, or I haven't responded. But what are you going to do? There is no revaccination. So therefore, it's best not to test at all.
What is the time interval you recommend after COVID to receive vaccination?
So no delay after COVID. As soon as symptoms have subsided and the acute infection is over, they can get the vaccine. There is no waiting period that has clearly been spelled out. No waiting period for people who've had COVID to get the vaccine.
Thank you very much, Dr. George. And at the end, I would like to say that we are also trying to do some research. We have, from our institution, we've got trials on for vaccines. We have the National COVID Registry on, and we also have ASPOT ADAPT, which is an Australasian COVID ADAPT study, actually looking at anticoagulants in COVID. So randomizing them and seeing them.
Wonderful.
So we are trying to do our bit. And thank you very much for that.
Not at all. The pleasure is mine. Mary has my email, or Jairaj has my email. You're welcome to shoot over an email if you have other questions that come up, and happy to respond. Thank you for the honor of this invitation. It's wonderful to reconnect with familiar faces and colleagues and mentors. So thank you for your patience and your time, and look forward to future such engagements.
Thank you. Thank you, George, for taking your time, and it's pretty late. And I also thank many of our alumni who have joined from Australia, Dr. Sumit and Dr. Harish and Shana also. And I saw friends of Ludhiana, Dr. Ed Dublin from Vancouver. It must be past midnight for him. And also many of the IMA members from Ludhiana and also nationally. And I also saw Dr. Divya Divya, the other from CMCL. So thank you very much. And if there are any questions, please send an email to us, and the talk will be available, and Dr. Dinesh will make it available for people who want that. Yeah. Thank you very much. Yeah.
Thank you again. Thanks, everyone.
Thank you, George. Yeah.
Bye-bye.
Bye.
Thank you, sir.